Oh, fantastic. Thank you so much. Thank you very much for inviting me. I think initially it was really good, and then I thought about it and the anxiety kicked in. So, yeah, the anxiety's definitely kicked in. But thank you so much for the invitation. So yeah, I'm going to talk about my kind of research. I've called it pain comes first, drugs come later, because that is I suppose the overarching kind of theme to it really, and it is around kind of rethinking the relationship between kind of mental health and substance use. And I think it's important to say what I mean by that is that when mental health and substance use collide, so when they both kind of coexist at the same time. The research began with a very, I suppose, a simple but an uncomfortable truth really, is that my experience now is that people use substances for many reasons. Mainly, from my experience, psychological pain, social, structural kind of difficulties, but they always come first. From the people I spoke to, that kind of pain always came first. And the difficulty is that our services rarely start from that reality. They start with, unfortunately, a lot of diagnostic boxes, tick boxes, abstinent targets, or funding rules. So I guess hopefully the research is there to kind of ask you really to rethink the starting point when we work with or talk to people with coexisting needs. So I thought I'd start with why I started the research more than anything. And the image on the right hand side, I hope it's the right hand side of your screens, is probably indicative of where we are in terms of dilemma at the moment. We are still very much in the phase of a chicken and egg scenario. What came first, mental health or substance use? So that was the kind of scenario that kind of got me thinking. But it was a real person, I want for a better word, that really kind of got me thinking about the research. I'm going to call her Jane. It's not a real name, but I met Jane probably about 15 years ago now in a women's prison. She'd been admitted or been sent to prison for drug-related offences. Jane had a very, very long history with mental health services, multiple different diagnoses, but she equally was using heroin, and she'd been using heroin for probably most of her life, really, especially from the kind of age of 16 onwards. And she'd always kind of stuck by the pretense that she'd used heroin to blunt out the trauma that she'd experienced in her childhood. The challenge was that when she was referred to mental health services, she was constantly told that she needed to be clean. She was constantly told she needed to be in a detox. And this created a bit of a paradox in a sense of when she went to substance use services, her mental health was too complex. Substance use services were great, they put on script, they really supported it, but always got to the stage where mental health became a little bit too complex and she was discharged. She persistently fell between the cracks of services, and it was ongoing, really, like I say, most of her life. She got released probably about 10 months after I started working with her. And 3 weeks later, we had an email that she died. She took a heroin overdose. Well, she died from a heroin overdose, sorry. And I suppose for me, that her life, her story kind of really resonated. And it just got me thinking about why we struggle to support people with coexisting needs. So that's where the research started, really. But unfortunately, Jane's story is not a kind of isolated tragedy. It's an everyday occurrence, unfortunately. So the problem at the moment, I guess, is, and I think it's important to tell you, these are estimates, really. We don't really fully understand the prevalence rates, but 70% of people in drug services also have a mental health problem. 54% of suicides among people with mental health problems involve substance use. And a recent report published by the Royal College of Psychiatry in 2025 is estimated roughly between a third and half of all people in either services will experience both. So this doesn't happen sometimes. This happens a lot. This happens more than it doesn't happen, unfortunately. So that's the kind of, I suppose, the problem I was initially faced with when I started the research. But there is a kind of wider impact. Now, I tried to do something clever here and kind of give it in terms of football stadiums, albeit I don't like football, so I don't know why I did it. But to put this in a bit of perspective from a wider impact, in 2023, 2023 to 2024, sorry, 3,790,826 people were in contact with secondary mental health services. They had a coexisting need. So if we use the statistics of the third and the and half, that would be between 14 and 21 Wembley stadiums would be needed to house them amount of people. Similarly, 2023-2024 substance use services had 310,863 adults were in contact with substance use services. Again, that equivalents to roughly kind of 104 million to 155 million. So that's between 1.2 and 1.7 Wembley stadiums, which is obviously vast. The numbers are incredible, really, in terms of how often this happens. But what I found really interesting was that there's a significant overlap here that we aren't aware of because we don't record the data. So it's the overlap in between the mental health services and the substance use services, and where them gaps kind of are. So that was, a huge challenge, and this is ongoing, very much ongoing at the moment. And just to kind of compound that, really, I just wanted to give you an idea from a lived experience point of view, and it kind of sits with what we've just said. So a lady I spoke to during the research kind of said, I've been referred to so many different professionals, mental health services assess me and then tell me to contact substance use services. They assess me, offer me support for my drinking, but provide no support for mental health. Yet mental health services won't take me until I stop drinking. But I drink because of my mental health. It's hopeless. So I felt it reveals the kind of systemic barriers and the secular challenges of accessing care. And what's interesting is that every person I spoke to had the same kind of story almost. And another lady I spoke to said it found it quite ironic that all professionals say they want to help, but as soon as they refer you on to somewhere, they disappear. I've had 4 alcohol detoxes now and still haven't had any mental health support. And guess what? I'm drinking again. So again, it kind of really highlights that unmet need more than anything. And they aren't just kind of sad quotes, really. They're kind of lived accounts of something that I'll explain shortly. Something's called morphostasis. So it means where systems continue to do the same thing over and over again, despite 20 years of kind of policies saying we need to do the opposite. So hopefully it gives you that real kind of lived experience kind of narrative, if you like. So I kind of started the research, and I chose Stoke-on-Trent for a number of reasons, really. One, I live in Stoke-on-Trent. I was born in Stoke-on-Trent, so geographically it was really kind of appropriate more than anything. But equally, unfortunately, Stoke's got higher rates of mental health and difficulties of substance use compared to national averages. Obviously, deeper socio-economic deprivation, housing instability, etc. And then it's got a long history of industrial decline, creating structural disadvantage. And again, the local kind of services mirror national fragmentation, making Stoke a microcosm of the wider system. And I don't know how many people are from Stoke, so I do apologise, but I've just put 2 pictures. The bottom picture is a market in Burslem, back in the I'd probably say late 70s maybe. Top picture is now, and that's not to criticise Stoke-on-Trent at all, but what I wanted to do was kind of give you the sense of this isn't just around a kind of medical element to substance use and mental health. There's so much more that we need to think about, again, from poverty, deprivation, disadvantage, industrialization, kind of deindustrialization. There's so much to think about. And I was really kind of conscious that we needed to look at more holistic picture. So I started the research. First of all, I did a freedom from information requests to 54 trusts in the UK. I wanted to get a kind of more of a macro kind of lens, really, in terms of what's happening around England. And what I found was that I kind of what we were experiencing locally was very much similar to what was kind of out there nationally. So 54 mental health trusts in England, 33 trusts responded, and out of that, 36% had a dedicated coexisting mental health and substance use service. 64% very much were in silo care, so had a substance use service and a mental health services separately. 74% had separate budgets, and then 58% had no lead agency. So for me, at a kind of macro level, the patterns were kind of unmistakable. They were very inconsistent. They had very inconsistent eligibility criteria. In some sense, fragmented commissioning. But equally, what it did show was that how it contradicted policy at the time. So policy from kind of 2022 to current, really, and always kind of advocated for this no wrong door policy, which unfortunately kind of the national picture didn't follow that. In fact, it contradicted that quite a lot. So moving on to the actual research itself, I use two lenses, bringing in the kind of freedom information requests at macro level, but I use two lenses overall. Overall, it was a qualitative study, but the two lenses I used was very much a critical realist lens and a phenomenological lens. Now, I know if there's any purists out there, this probably doesn't make any sense at all because the two are very different. But what I tried to do in the research was hold that tension between the two. I never conflated them. I never brought them together. I used critical realism from a macro point of view, and then phenomenology from a micro point of view. Critical realism for me was it was amazing because it kind of it rejects the easy but misleading choice between blaming the system or blaming the person. And I guess I wanted to make that very clear. This isn't a criticism of individual practitioners. I am one of them practitioners. So it's certainly not a kind of criticism of them. It's not a criticism of the local authority or NHS trust. What it is a analysis really of the system as a whole, which I believe the system just simply doesn't work the way it's designed at the moment. But it began with a very simple idea that reality exists whether we see it or not. So, but our view of it is very incomplete. So, for an example, one of the kind of trusts I spoke to had a policy on waiting lists. So, one of the policies was that you had to be substance free before you could come on the mental health waiting list. Now, when I talk about critical realism, that kind of sits very much at the top of that kind of, it's a real force. And what I mean by that is that piece of paper, a practitioner might read it at some point, but the person accessing them services would never have read that policy. But the impact of that policy is very real. That policy itself has causal power, and it impacts just how that person is going to get care. So I wanted to kind of look beyond what we saw and look at what was out there, what was preventing us providing that kind of work, really. So the question I asked was, what challenges do people with coexisting mental health and substance use face, and how do they shape treatment and recovery? We've talked just about the kind of freedom of information requests, and that very much exposed them structural gaps. I then looked from a micro point of view, looked at the interviews using the phenomenological lens. So I did 24 interviews, 12 with people with lived experience and 12 with professionals capturing that lived reality. And again, what was really interesting is that I came into this with a kind of thinking that, you know, when talking to professionals, they would probably, I guess, feel that frustration, but equally have ideas about how to move forward. And what really surprised me was that actually they was they were just as frustrated as the people trying to access the support. Moral injury was played a massive role within that as well, and compassion fatigue as well. So yeah, sorry, just to go. So what I was trying to kind of get from the critical realist kind of stance was to understand what was, I suppose, what was causing us not to be able to support the people. And that came out very quickly from the professionals' interviews as well. And one thing that kind of really jumped out there was we still have the Misuse of Drugs Act 1971. This is just an example. And it was the term misuse that I found really interesting. It was brought up quite a lot, in a sense of practitioners working with people using that term misuse. It created a moral judgment straight away. It existed for over 50 years. So before people have even hit services, they're already stigmatized, moralized by law, saying that they're misusing substances. What I understood from the lived experience, they don't misuse substances, they use substances. And actually they use them for multiple reasons indeed. But moving on, so I kind of I used a framework from a lady called Margaret Archer, and she kind of created something called the morphogenic framework, which shows how structures, people across time, work together almost. So at a starting point, we inherit conditions. So like the Misuse of Drugs Act, we inherit that. It has to be the starting point. Budgets, professional silos, centuries of moral judgments, etc. We inherit them things. So before they access care, they're already faced with historical judgments, let's say, historical kind of compounds, if you like. So I looked at something called the morphogenic loop. Margaret Archer puts it into kind of 4 ways of looking at it. So T1, T2, T3, and T4. So for T1, it looks at the concept of structural conditioning. So as we're talking a little bit just about Misuse of Drugs Act, for instance, structural conditioning is the stuff that we don't see but is always there. So precarious housing, poverty, racism, rigid policy thresholds, historical moral governance. It's stuff that kind of hasn't changed, unfortunately, for generations, centuries, if you like. And then what happens then is it kind of leads into something she calls T2, which is the cultural mediation and agency. So it then looks at how people cope, I suppose, within those structural conditions. And again, from a lived experience point of view, survival strategies emerge. So, drinking for sleep, using heroin for flashbacks, withdrawal for safety. It was more around how people learned or survived within those structural conditions. And then moving into T3. So this was more around kind of institutional responses, how mental health services, substance use services, etc., responded to T2. And a lot of the time, it was through abstinent before care motivation tests, SALAD referrals. Ultimately, we were asking people to conform to the system, but the system wasn't allowing it to conform to them. And that's despite lots and lots of policies saying the opposite. And then T4 is where Margaret Archer kind of talks around structural elaboration. So 2 things can happen when we get to T4. Morphostasis, so we just reproduce T1 conditioning. The morphostasis loop continues basically, or something called a morphogenesis, where change happens. So in my argument, we adopt a very much an integrated care system. And the exit strategy would be safety first, stabilization. Exit 2 would be recognition, led plan, testimony, drive care, no abstinent preconditions. We create a system that doesn't gatekeep, that doesn't kind of ostracize, but actually what it does is it then lends itself to the person's needs, where at the moment, unfortunately, we do the opposite at the moment. So they were the kind of almost the findings really from the critical realist perspective, and then moving on from the thematic insights kind of element to things. What I found initially was that abstinent first was everywhere. Everything we did, we had to be abstinent for. Policies demand abstinent care before they could kind of access any sort of services, especially mental health services. Siloed referrals, hampered fluid care pathways. Again, as as the people in the interviews were saying, everywhere they went, it was kind of you need to go on a detox. You need substance use services first before we can treat your mental health, or your mental health was too complex. It was a constant cycle of morphostasis. So it was constant reproduction of the fragmented systems. We had mental health services, substance use services, housing services, social care, all fragmented. But saying that, there was a few services that kind of had taken on the challenge of an integrated model. So there was some services that were looking at change, so morphogenesis, so the potential of change through integration. And what was really surprising, or not necessarily surprising, but really nice to see, was actually when they integrated services together, it really, really worked. People may not have kind of seen a massive decline in the use of substances, but what they did see was a much better service, much better interaction, much better kind of collaboration between the services. It was really nice to see. But then there continued to be a tension between system inertia and transformation. So the morphogenic loop illustrates the ongoing struggle between maintaining old structures and embracing change. The particular service I was thinking about didn't last very long, unfortunately, due to funding restrictions. But while it was there, it did really, really well. So they're the kind of findings from a kind of structural elaboration perspective. From a lived experience point of view, the findings were, I'd like to say they were surprising, but unfortunately they weren't. There were a lot of societal stigma was still very much there. And in part kind of played a huge part in institutional stigma, and equally the persistent myth that substance, you need to be substance free. People internalized that kind of judgment and they described themselves as the lowest of the low. The structural element of things, where policies and laws criminalize or exclude, each layer reinforces the other, and shapes kind of how people approach the services. And that kind of brings me back to the kind of point of pain comes first, really. It has to be the starting point. It has to be the point in which we go, okay, yes, you're using heroin, yes, you're using monkey dust, etc. But why? What is the reason? What does that substance do for you? It's not a slogan. I don't want it to be a slogan. It's more of a description of reality. People don't drink or inject or inhale because they have misread a rule book. They use substances as a survival technique to pain, psychological, structural, or social pain. That's already present. So yeah, distress, substance use, and merge together. I would argue that actually what happens is they start to co-emerge, and there's lots of kind of evidence in that in the brain disease model of addiction, the medical models of mental health. They do co-emerge. One then triggers the other, but the starting point was always the mental health kind of side. The sad thing is that for decades our systems have been built on the opposite assumption. It is almost that kind of, it's been that split where we look at them as separate entities when they have to be looked at as one. And in a way, what I thought was the kind of the points of bringing them services together, despite the weight of change, there were pockets of change, should I say. So when services integrated, absent goals rather than a gate shortening the time of the first contact, and the supported roles from a peer point of view, and the cycling shifts. What was really, really surprising was that it really worked. Like I said before, it was absolutely fantastic. And the examples show that change is possible when structure and agency align. It's hard and it requires a lot of kind of change, but what was really, really interesting is it worked really well. And I guess for my research, what I kind of proposed, it was initially called the integrated morphogenic cycle, but it was a bit of a tongue twister. So I proposed a layered care model, and it was built on 4 pillars basically. One was structural flexibility, and that kind of fits in hopefully to what I've just said in terms of there is no absent first model. The services would bend around real lives rather than forcing people through rigid pathways. So that means kind of pool budgets across teams, commissioning, so no one is left stranded between mental health and substance use. And then integrated social determinants, that's kind of like treatment without secure housing is difficult, or safety. That needs to be the first kind of point of call. Care has to be addressed, within them conditions. But we have to consider that as well. We have to consider treating someone who's homeless. Is it possible? Okay, well, no, let's secure the housing, which is, I understand is difficult. The third one is enhanced agency. So people making rational survival choices inside very tight kind of limits. Understand why that is. Understand that people use substances for a particular reason. They don't wake up one morning and think, today I'm going to become alcohol dependent, or tomorrow I'm going to be dependent to heroin. It's a choice based on survival. They have to survive. That's the only way that they know how to. The fourth is conceptualized care. So what works in Stoke-on-Trent probably won't work in Glasgow or London. So it's looking at local cultures, resources, histories, and how they shape good care. We together the kind of the pillars form a system built on complexity, not compliance. One that starts with pain and builds on toward the kind of supporting the whole person, one for a better word. So I know I'm running out of time. So next steps. For me, services must start with pain, not abstinence. Integration is a design choice, not an impossible dream. And unlike kind of services are built around pain, exclusion will remain. Sorry, until services are built around pain, exclusion will remain policy by default. And what I mean by that, just to finish off, is that for 20 years, since 2022, we've had the dual diagnosis practice guides, we've had commissioning better care, and they've all said the same thing: we need an integrated system. And I think hopefully my research proves that in spades, in a sense of everybody from practitioners to people with lived experience are saying that it needs to be an integrated system, and that integrated system needs to start with mental health, i.e. pain comes first.